It's a real great pleasure to introduce John, who of course needs no introduction, past president of this society and of BSET, senior editor for the European Journal and past chair of the SAC. But John's talk today really comes out of his commitment to data-driven quality improvement. And he's really done that through his time as the chair of the audit committee, an MBR lead. And it's probably fair to say that without John, we may well not have an MBR. So his commitment's been incredible, and I think he's taken that through now to NHS England roles, GERFT with Rachel, through the medical devices work, and through NSIT work. And I think it's really fitting, John, that this is a meeting where we've seen Penny present for the first time medical device data for the aortic devices, and we can really see that how the impact that's going to have going forwards. Straight after you, we have a Hunterian lecture, really based again around your commitment to developing data-driven quality improvement. So it really is an absolute pleasure, John, to introduce you for this BJS lecture, which is on optimising outcomes in patients with critical limb threatening ischemia.
Thank you very much, Marcus. Thank you to Ian for inviting me. Relatively short notice in London, or a bit of a surprise. So yes, I'm going to talk a little bit about critical limb ischemia. I've got a few disclosures. I'll be using some GERFT data. I'll also be using some NSIP data in this presentation. And I did share the PAD QIF writing group, although the nice graphic which everyone now shows was actually mainly Marcus's work, so thank you, Marcus, for that. Marcus has already touched on these two individuals. I think this is an acknowledgement that the Circulation Foundation in particular, but also the Vascular Society and the Royal College of Surgeons decided to invest in two fellows, and these two fellows have produced an awful lot of work. I will be touching on quite a lot of the work they produce, so it's their work, not mine. I'm going to try and steer clear of most of Ellie's work, because she's going to be speaking after me. But I think this shows how powerful the Circulation Foundation and the Vascular Society can be if we invest in our junior colleagues. So I'm going to run through a little bit of background. I'm going to talk a little bit about the impact of delay and the causes of delay. I'll go through a bit of the quick stuff. Interestingly, there's been quite a lot of impacts of reconfiguration. I'm going to talk about the sequin, some of the outcome data, both the variation and subsequently optimising the data. So we all know peripheral arterial disease is bad and critical limb ischemia is bad. It's got mortalities higher than many cancers, and we know from the work we've been doing there's quite a lot of variation around the country in terms of both care and outcomes. I quite like this little bit of information about amputation rates, partly because Hull only came second and not first, like last night. But you can see that there's some places in the country, mainly in the north, where there are very high amputation rates. I'm going to talk quite a lot about delay, and interestingly, most vascular specialists think delay is important with critical limb ischemia. But actually, when you look at the data, when we started looking at the data at the outset of this work, there wasn't much data to support that delay meant worse outcome. This is a patient from Cambridge in the summer, and one of my colleagues was looking after this patient, but the picture on the far right and the second picture in were 1 week apart. So this was initially managed as an outpatient, came back a week later, subsequently had a revascularisation, which was obviously delayed, further amputations, major limb amputation, and sadly this patient died. And you can really see in this patient that delay in revascularisation, potentially by a week, made a significant difference to possible outcome. This is work from Leicester, so this is work, a meta-analysis or systematic review looking at delays. This was published in 2020. And it demonstrates delays in all aspects of the management pathway. Patients don't really understand what PAD is or CLTI is. There's poor healthcare assessment, and there's barriers to referral and treatment. I'm going to come back to this later on, because a lot of these things are still present today. This is an editorial that Penny wrote on the need for speed, and I say we all recognise, I think, as vascular specialists that we need to treat these people earlier, but I say actually the evidence to support that is not great. And certainly when we started this work, there wasn't much evidence to back that premise. But we do know that in the other cardiovascular diseases, there's very good evidence now that early treatment for stroke and heart attack improves outcomes, and probably it should be the same for peripheral arterial disease. I say limited evidence for CLTI, and there were no real targets when we started this work for CLTI prior to the PAD QIF. This is Mike Horrocks's report from 2018, so this is the first GIRF report in vascular surgery, and it identified long waits for clinically urgent procedures. It wanted us to revascularise people earlier, to reduce amputation rates, and it charged the Vascular Society with developing a quality improvement framework for peripheral arterial disease. So I'm going to touch a little bit on that. I've mentioned it already, but this has become an important document. When we did this through the audit committee of the Vascular Society. We took wide stakeholder engagement, so we tried to involve everyone we thought was important, and you'll see that if you read the documents at the end, the number of specialists that are involved, but we involved most of the allied vascular societies. And it really focused on a timeliness of intervention for CLTI. We first published this in 2019, and then it was updated in 2022, and it's probably fair to say, Marcus, it's probably due for another update. But this has turned out to be quite an important document. I think in the sessions I've been to at this meeting so far, I've seen this slide probably 5 or 6 times already. And it's fair to say when we did this was expert opinion. We didn't really have anything to base these numbers on, but we sat together and we sort of discussed it, and we ended up coming up with these 2 numbers, which was 5 days revascularization target for those patients admitted as emergencies with critical limb ischemia, and 14 days for those who were being managed as an outpatient, perhaps with slightly less severe disease. You could argue that patient I showed you earlier on was managed as an outpatient and didn't come to the best outcomes. So these numbers were really based on expert opinion. But we have now got some data on delays, and this is work from Penny that was published earlier this year in the European Journal, and this looked at delays in revascularization and the subsequent outcomes related to the patients who'd been admitted as emergencies. So this was based on HES data, about 10,000 patients between 2017 and 2019. Here you can see, again, this group of patients has high mortality, so more than a quarter of these patients were dead within a year. 15% had major limb amputations within a year. But from this work, it was very clear that delay from admission to revascularization was associated with mortality at 1 year. So the longer you waited to revascularize the patient, the more likely your patient was going to die within the first year, for those patients who presented with tissue loss. And if I break that down further, you can see here from the KM curves that delays out beyond 16 days almost doubled the mortality at 1 year. And for every day's wait beyond the first day of admission for revascularization, there was a 3% increase in mortality at 1 year. Interestingly, in this study, there's no association between delay and major limb amputation. This data was all adjusted as best we could through HES for age, sex, diabetes, comorbidity, frailty, level of disease, and type of intervention. So, and I can tell you something, Penny is very good at statistics, so this is adjusted as best we could. But there's a clear signal here that delay in revascularization results in higher rates of mortality at 1 year. This, however, is obviously only the end of the pathway. So these are the patients with end-stage disease who end up presenting as emergencies, and it doesn't take into account that long lag from initial symptoms to treatment. So this is a study from the US, over 1.3 million patients with critical limb ischemia, 66 to 86 years in age, of whom about 100,000 were managed with endovascular treatment as an outpatient within 180 days. So this is earlier in the pathway. So we're now looking at patients before they get to us as an emergency admission. We're looking at people who managed as an outpatient. So in this cohort, half the patients were revascularized within 30 days. So half this group had an angioplasty within the first 30 days. And there was no association with major limb amputation or death if you had a revascularisation in the first 30 days. However, for each additional 10 days beyond the 30, there was a 2.5% increased risk in major amputation. I'll just show that data in a little bit more detail. So here you can see for each 30-day delay beyond the initial 30, so out to 180 days, for these patients who have been managed with critical limb ischemia as an outpatient, had a 7.6% increase in major limb amputation rate at 1 year. So this is looking at slightly earlier in I suppose, the disease process, but again, it's clearly showing that delay for outpatient management led to more amputations. I want to touch on a little bit of reconfiguration data. So reconfigurations happened significantly over the last 10 or 15 years, we all know that, but I think probably it has had some impact on the way we manage critical limb ischemia, peripheral arterial disease. I was fortunate enough to be an examiner on Peter Holt's thesis, so I've still got these photographs from doing that. And so this is what vascular units looked like in about 2010 in England. And Peter was seeing into the future because he predicted that the number of units would drop as we went through a centralisation process. And this is what he thought it was going to look like around about now, and he's not far from the truth. So we have had a massive reconfiguration in vascular services over the last 10 to 15 years. I know London's not on this map, so I thought I'd just put it on there as well, but you can see here multiple units in London, which were going to be reduced to about 8, which is, I think, is roughly where we are now. And certainly some work I did with Ian Loftus, we know that for aneurysm surgery, the number of units performing aneurysm surgery from 2012 to 2022 reduced from 132 in the UK to 64, and we know it's fewer than that now, so there's still ongoing reconfiguration. But the centralisation of vascular services was really driven by a reduction in aneurysm and carotid mortality and stroke. It didn't really take into account the complexities of a comprehensive vascular service, and the evidence to support centralising peripheral arterial disease, and particularly lower limb bypass and angioplasty, was less conclusive. But we pushed ahead with centralisation of services anyway, because we thought the aneurysm and carotid patients were important. This is more HES data. This is again from the NBR team, so this is Kiji's paper, and again, I think this is a very important paper. This looks at patients presenting to the hub or the spoke, both as inpatients and outpatients. 16,000 patients with CLTI. If you presented directly to the hub and were admitted, you had a revascularisation within 5 days. If you were admitted to the spoke, your revascularisation took 12 days, so more than twice as long. Similarly, if you managed as an outpatient and presented to the hub, revascularisation within 13 days. But if you presented to the spoke, 26 days, so again, twice as long. So patients presenting to the non-arterial sites are not getting an equitable service to those who present to the hubs. And in this study, because again, a number of these are outpatients, delay in this study was associated with major limb amputation and inpatient death. This is the same data, but you can see here the amputation rates rising with delay. And you can see in the red circle, these are the patients who have managed through the hub, through the spoke, sorry. So the patients managed through the spoke, it's clear they had delays. And that delay led to worse outcome in terms of amputation. So I hope I've showed you through those few papers that delay leads to more major limb amputation, more death of a year, more inpatient death. I'm going to touch on the sequin. I think before I get into the sequin data, I think this is another real success for the Vascular Society. Vascular surgery is a small specialty. There are 4 or 5 sequin projects a year for inpatients, and actually this is a fantastic achievement for the society to actually get vascular surgery recognised and a sequin in our own specialty. This is the sequin for the second year of the sequin. So we had a target of 45 to 65% of patients being revascularised within 5 days. So these are the emergency admission patients, not the outpatients. So the sequin was targeted at the emergency admissions. The interesting thing here was that the data from the MBR in 2021 showed that if you were revascularized within 5 days, your length of stay, on average, your median length of stay was 9 days. But if you waited more than 5 days for your revascularization, your length of stay was 21 days. So significantly increasing length of stay if there was delay in initial revascularization. Did the sequin help? Well, it did. It seems a bit modest, but effectively, by the end of the sequin, we'd moved from, in England, from 47% of inpatients to 55% of patients being managed within those first 5 days. Rachel and I, as you're probably aware, have been going around the country, and Rachel I haven't got much hair left to pull out, but she sees me frustrated when we go to places where we've seen this, and this is very frustrating. So this is a unit where clearly there was no engagement from the vascular services, vascular surgeons, IRs with their managers to try and improve their performance. And this hospital would have lost probably about £1 million over 2 years. We don't see that very often, but it depresses me because we've had an opportunity to really raise the profile of critical limb ischemia. Most units aren't like that. So here are the headline figures. So sequin, 47 to 55% from the start to the finish. But the main thing to say is that every region in the country did demonstrate some quality improvement in terms of the metrics we were looking at, and more trusts started submitting data. Now, I told you earlier on we're down to 51 vascular networks in England now. The reason there's more trusts here is that angioplasty gets performed at more than just the arterial hubs. It also gets performed at the spokes. I said I was going to touch on variation. So this is some of the variation from the sequin. And you can see here that some units are performing extremely well in terms of revascularization. This data is for the whole NBR, so this NBR data, so this covers all 4 nations. But you can see massive variation in the 5-day target. So I'm going to go on to talk a little bit about variation. I'm going to show you some NSIP data. There is an NSIP stand at this conference, and I'd encourage you who haven't engaged with NSIP to go and do so. Ursula is there, happy to talk to anyone about NSIP data, particularly clinical leads. But we know there's variation in outcome. So this is a quality metric, readmission after lower limb bypass, and you can see from this that this is a funnel plot. Vascular surgeons, we're quite used to looking at these, and a lot of the NSIP data is presented as funnel plots because we tried to model it on the NBR when we set it up. Most of us understand these, but you can see here that there's a variation from about 0% to 34% readmission rates after lower limb bypass, and that's clearly an unacceptable level of variation. Some of the hospitals in the country are outlying, so that they're outlying on readmission. These are some longer-term outcomes. One of the other things you can get from NSIP is longer-term outcome metrics. So this is mortality within a year, and major limb amputation within a year. So NSIP will provide longer-term outcome data. Again, there's one hospital here outlying for major limb amputation after lower limb bypass. And it's similar for angioplasty. So readmission after lower limb angioplasty, we've got a number of hospitals outlying here, and rates varying from 0 to 25%, when you've got national average around 13%. All the NSIP data is based on 3-year outcomes, so we try and present longer term and larger volumes of data. And again, with angioplasty, outliers for both mortality at 1 year and amputation at 1 year. So Ian really asked me to talk about optimising outcomes, and I hope I've showed you some of the data that says that we're not doing particularly well still in some areas, but how do we get better? I'm going to start off by going back to some of the Leicester data. So this is the original publication after Leicester set up their hot foot clinic. So this is a every day of the week clinic, nurse-led, vascular scientist duplex, same-day CT access, and access to both endovascular and hybrid theatres for revascularization. And this initial data demonstrated that by setting up this service, comparing to historical cohorts, the Leicester team were able to demonstrate significant reduction in major limb amputation rates within the first year. John Houghton's gone on to update this data set. So this is hot off the press. So this is published this year in the European Journal. comparing their bowels patients with a historical cohort. And again, you can see here that by having a hot foot clinic, they've managed to reduce their major limb amputation rates from 11.1%, from 25% to 11.1% at 1 year, and a significant reduction. So it looks like hot foot clinics are beneficial to our patients and they reduce amputation rates. I couldn't not discuss this. So this is the Manchester Amputation Reduction Service. So I don't know whether Naz is in the audience. I've seen John Gosh here, but Manchester have made fantastic advances in managing their patients. And it's a slightly different approach. They've gone for a whole system approach. They've integrated multiple services. They've raised capabilities in the community of both nursing and podiatry teams. And they've really looked to reduce inequality to access across Manchester. The initial pilot area was Salford, and they showed a 42% reduction in amputation rates in Salford in 6 years. I'm going to touch on a little bit of this. I know Ellie's coming in later, but some of these themes we saw earlier in that earlier work from Leicester. So Penny's done a lot of qualitative research. Ellie's done a lot of qualitative research. She's going to come and talk a lot about this later, but we know that patient awareness of PAD is bad. Primary care clinicians lack knowledge of CLTI. Patients often have multiple visits to GP, emergency departments to find somebody who knows what to do, make the right diagnosis and refer the patients appropriately to vascular services. And there are still barriers from community to vascular services in hospitals. Ellie identified lots of things we could do to help, and a lot of this is working with local partners, so it's working a bit like Manchester did with podiatrists, primary care physicians, community nurses, trying to raise profile, trying to educate, to ensure that we get timely triage to our services. I'm going to move quickly on because I think Ellie will talk a lot more about this. She also identified some national targets. So we probably need to have better national guidance for CLTI. We certainly need to raise the profile. I raised the stroke fast programme. This has done significant benefit for patients who present with stroke, and we probably need to have some sort of similar programme to raise awareness of critical limb ischemia. We need to educate both clinicians in the community, but also the general public. And I think one of the biggest steps we could take is working to try and get a transformational vascular CRG. It's not quite clear whether CRGs are going or specialised commissioning is going in the DOH, NHS England combination, but we really could do with a vascular transformational CRG because cardiac surgery would really benefit from this. I think we probably need to start engaging with people who can help us, and I think there has been quite a lot of engagement with the APPG in vascular and venous disease. We heard some talks about this earlier in the week. This is a claudication supervised exercise meeting I went to recently, which was driven by Hull. But yes, I think this group has been very helpful in raising profile. Amputation is a motive. MPs do not like having lots of constituents who've got amputated legs. So I think we can work with the all-party parliamentary group. I think we can, hopefully, by doing that, raise profile. And there's certainly lots of synergies within the 10-year NHS plan around PAD. So I think we really need to take advantage of the links we've already got with the APPG and promote those. We also need to embrace industry support. So these are two things that happened within the last year. Act Now to Save Limbs and Lives. That was driven through the APPG, but also with the help of Shockwave. So Shockwave recognised that we need to raise profile, and they helped support this through the APPG. Now, I'm sure many of you have seen these photographs from Rankin, the famous photographer of amputee patients that was done at the back end of last year, early this year, in the Ampunation Project. And this raised profile. This was on the front page of Vascular News. And again, this work was supported by Abbott. And I think as vascular surgeons, we have to look at every way we can raise profile about PAD. And I think working with industry going forward is going to be very important. So I'm going to pretty much sum up there, but I think the take-home messages, I think there's no doubt that the PAD Quality Improvement Programme and Framework and the CQN have significantly raised profile in the UK. There's a much greater focus on the timeliness of intervention. I think certainly now in England people recognise the 5-day target for inpatients is important, and it's widely been adopted into clinical practice, though I do recognise the data Penny showed yesterday that we're drifting back to where we were at the start. So I think it's important to keep flagging this. I hope I've showed you data today that says delay in revascularisation for these patients results in higher mortality at 1 year, higher in-hospital death at primary admission, and higher major limb amputation rates within the first year. So, thank you very much.
So we don't take questions after these lectures, but of course John will be around to answer any questions. I would just like to recognise the partnership between the Vascular Society and the BJS, who for this meeting have supported both the prize session yesterday and the prize, and also this lecture. I'm also delighted that we still have a very strong input into the BJS Academy, with Rob Hinchcliffe having taken over from Jonathan Earnshaw as Editor-in-Chief for BJS Academy. Whilst we don't have a medal for this particular lecture, the lecture will be published online on the BJS Academy, and I'm hoping, like we did last year, actually we've had such strong contact this year that some of the other sessions will also be published on the BJS Academy. So I'd just like to finish by formally thanking and congratulating John on his lecture. I'm sure you'll join me in just saying thank you to John for that fantastic talk.